Hi, this is Terry QT, founder and director of Deep Sea Foundation. Welcome to the educational channel where we talk about all topics related to breast reconstruction for those affected by breast cancer. I'm joined today by I'm just going to say they're two great friends that I have met in my foundation work. And my first guest is Dr. Patricia Clark, who is an oncoplastic breast surgeon, and she is in Scottsdale at Ironwood Cancer and Research Center. Dr. Tim Matatov joins us from the Phoenix area, very nearby, and he is with the Aesthetic and Restorative Breast Center in Phoenix, and he is a microsurgical trained breast reconstruction surgeon. We're going to talk to them today. We're kind of in a unique situation because in a shared decision-making model, what we do is take the patient's preferences and their lifestyle, what their desired outcomes are. There's a whole lot of things that go into it. When I had my double mastectomy and then moved on with my breast reconstruction, my shared decision-making conversation started with my breast surgeon. So we're going to start with Dr. Clark, but what I would like for you guys to address, because you geographically work in the same area and you also work together on your surgical cases, let's talk about how you two coordinate your efforts for patients. But in the conversation, I'm hoping that even those patients who, like myself, breast surgeon in one town, plastic surgeon in another, give us the vocabulary that we need or that patients need to hear so that they can have this shared decision-making conversation with their breast surgeon and their plastic surgeon. And then at the end, let's talk about the current pandemic that we're in. But Dr. Clark, I'm going to let you start and talk about, how that begins at your office for patients.
Okay. Thank you very much for having both of us do this too. I just love when we have a chance to share with the public. So generally, if a patient has a new diagnosis of breast cancer, their primary care physician or their gynecologist will send them to the breast surgeon. So we usually see the patient first and become the initial quarterbacks. The breast cancer care team consists of both the breast surgeon, a medical oncologist, often a radiation oncologist, a plastic surgeon, maybe physical therapists, nutritionists, or quite a few people involved. So when I first see the patient, I try to get an assessment of their wishes. I look at the tumor, I look at the family history, I look at the biology, and the first decision tree that we come to is, would that patient require breast conservation or a mastectomy? What is their preference? I also look to see if they might need chemotherapy, which if they do on some of these more aggressive or larger tumors, we may do that before they ever have the consultation with the plastic surgeon and before surgery. If they need chemotherapy first, it gives us a lot of time to really hone down our treatment options, and they don't have to make a decision quickly as far as their surgical options. So let's say I have a patient that is not going to need chemotherapy and they need surgery. So I explain the benefits of breast conservation, generally with radiation, versus mastectomies. Breast conservation, I will explain, the simplest is just a straight lumpectomy with a hidden scar. But a lot of women have tumors in an unfavorable position, say the upper inner quadrant or the lower quadrant, where if I did a simple lumpectomy there, they would have quite a bit of deformity and denting, disfiguration. So if they want a breast conservation, they may need an oncoplastic surgery procedure. And that is a procedure where they're going to combine the oncologic surgery, where I take the tumor out, but also with a plastic surgery technique like a breast lift or a breast reduction or a tissue rearrangement to repair that defect. Oncoplastic surgeries are performed usually in the United States by plastic surgeons working in conjunction with breast surgeons. There are some breast surgeons who also have additional advanced training in these plastic surgery techniques, and they may choose to do that by themselves. So if I have a patient that I know wants a breast conservation and they may need oncoplastic surgery, I'll tell them the advantages of having a plastic surgery, help me out with that, versus me doing it by myself. And then if they want a mastectomy or for some reason can't have a lumpectomy, then their breast reconstructive options are either go flat, don't do anything. They could, if they have very, very large breasts, sometimes we can keep the breast skin that we would normally throw away, tuck that in. That's called a Goldilocks mastectomy. Or if they want reconstruction, it's traditionally an implant-based reconstruction or autologous reconstruction where we use a patient's own tissue. So I'll lay out those options, and then I want the patient to see the plastic surgeon to go find out what are the advantages of each one of those approaches. So after the first appointment with me, I'll set them up while they're going off to see the plastic surgeon. They'll also see a medical oncologist and a radiation oncologist, just so that they really have all the information. So that's my starting point. Next, I'm going to pass this off to Dr. Matatov because he can start in on where his part comes in.
Yeah, and like you said, it's such a coordinated effort. So Dr. Matatov, tell us then where you come into all of this conversation.
Sure. So, you know, a lot of times in active breast cancer, we receive a phone call from the breast surgeon's office for a consultation. We get appropriate paperwork. So a lot of times I'm prepared and know ahead of time what's the situation with the current care of that particular patient. And majority of the time, Dr. Clark and I get on the phone and talk to each other before the patient gets here, so I can get a full story coming directly from her. So when I see the patient, I know majority of the information to some degree. You know, you don't always predict if the patient is going to get chemotherapy or radiation therapy, but at least the surgical plan comes together a little bit easier for me because I'm already seeing them after Dr. Clark formulated a plan. And I discussed with the patients, you know, I like to talk about for me at least, the kind of 3 pillars of reconstruction. We talk about breast cancer treatment as one pillar, also functional reconstruction is number 2, and then aesthetics. So if the patient's going to get a lumpectomy, then we have a conversation of having an oncoplastic reconstruction to treat the area of a defect on the cancer side. And a lot of times you have to address the contralateral breast, whether it is a reduction to match the other side or breast lift. And in general, I like to keep the cancer side breast slightly larger than a non-cancer breast, because majority of the time patients undergo radiation. There's some atrophy that occurs. So that takes a little bit of planning from that aspect. Now, if I know that the patient is getting a mastectomy, well, it's either unilateral or bilateral mastectomy. If the patient is getting a unilateral mastectomy, my preferred option would to do an autologous reconstruction using patient's tissue, because the match to the non-cancerous breast is significantly better. Certainly some patients are not candidates or may not wish to do that, and an implant reconstruction is another option to undergo that. Now, if the patient's getting bilateral mastectomy, so we obviously also talk about implant reconstruction and autologous reconstruction. I do both in my practice, but my preferred way, if the patients are candidates, whether it's medically or enough tissue, would be an autologous reconstruction. And I also have a conversation with them about staying flat. And if I don't think I can deliver the result, or seems like a reconstruction is a more of a challenge for the patient. You know, we go back to the pillar one, which would be treatment of breast cancer, and reconstruction may not be what that patient needs right now, or may not need it at all. They just don't want to. And when we talk about functional reconstruction, that includes, performing an actual DIEP, where we preserve the muscles and nerves, or any other flaps that preserve function. And that to me would be what I consider a functional reconstruction. And aesthetics, as far as matching the breast, would be something that we discuss as well. And that's why, let's say in a unilateral mastectomy, autologous reconstruction would be the best option. So after that, once we figure out which way the patient is leaning towards, and sometimes you don't know, and if in the cases you don't know what's going to happen, I just offer a patient an expander. Let the things cool off. We'll convert the patient from active to non-active breast cancer. And if they need a radiation, post-operative chemotherapy, or anything else, we can do that, and then proceed with permanent reconstruction. And also lets the patients kind of make a decision that's not rushed, and they have time to think about it. Because when they come in, they're in a hurricane, and my job is to kind of get them through the hurricane and then let them make a decision when they're in a better situated position, and not making a rash decision. And some patients may choose a reconstruction with tissue and initially wanting an implant, or vice versa. So this allows them to make a decision that's calm and educated. And then I coordinate with Dr. Clark's office to schedule this surgery once her and I talk and we agree on the plan. And we try to get the patient scheduled as soon as possible.
Wow. I mean, you both gave such excellent information. I hope I'm not getting too much feedback here. I'm hearing a little bit, so I hope that's not coming through on the video. But so, I mean, that is really the summation. And Dr. Matatov, love the 3 pillars. I learn new terms all the time. And that's my new favorite term, the 3 pillars. That is excellent. But here's my question for the current situation. Shared decision-making does not stop during a pandemic. You guys are offering virtual consults. You can't have all your patients right there in Arizona. I'm assuming you have them come from around the country. So address that with us. How are you doing with the current we're in the middle of the pandemic right now. I don't think it's going away anytime soon as we see these peaks and valleys. Can you tell me about that?
I'll start on that. I think Dr. Matatov may have more coming from around the country than I do, because he is performing the DIEP flaps, and a lot of those are not under the gun. And a lot of those patients have really done some shopping and done their research and selected out different teams around the country before they've decided upon his. With mine, I have quite a few patients that do come from other states, and most of them had a breast surgeon in other cities or other states that for some reason they're stuck in Scottsdale now. We have a very large population here of people that live here off season, like in the winter or in the summer. So I'll get referrals that way. Those referrals, I generally will talk to the breast surgeon in the other city. They will forward all of the paperwork, the biopsies, the imaging. Most of those patients do have a one-on-one visit with me. I really need to see that breast, and I need to look at the imaging with my own eyes to figure out exactly which procedure may be the best for them. When I look at a breast, I want to know the size of the breast. I want to know the shape of the breast. I want to know the size of the patient, because we have some tiny women come in here, and we have some women who are on the larger size. it's all across the board, all different ages. We have, there's a different degree of sagging with women. There is a variation in the skin quality where some are very elastic, some are not. Some people may need to have extra baggy skin removed when I'm done, just not to be too graphic. But there's a lot that goes into the treatment planning when I first see that patient. So I really prefer to have them in the office. Once I have them in the office, if I need to do more workup, get more imaging or something like that, with the current pandemic, I'm going over a lot of the imaging virtually. So we are doing some telemedicine that way. I think that's become a little bit more my practice than it used to be. Now that I've done quite a bit of telemedicine now, I really find that actually seeing that breast and putting all the information together has worked better in my practice.
Well, and you know, to your point about Dr. Matatov too, if you're considering autologous reconstruction, it really a lot of times comes down to accessibility, because it's a very specialized type of plastic surgery. You fall under the umbrella of plastic surgery, but it requires, you know, hours, months of extra training. And so it becomes an accessibility issue. But to your point also, Dr. Clark, about the various types of things you have to consider, I always call a patient, you know, the canvas that you both have to work with the skin laxity, size, shape, all of that. So Dr. Matatov, how are you dealing with all of the considerations during the pandemic with your virtual you know, consultations?
Well, initially when we're at the initial wave or in Phoenix, or we actually never peaked at the first aspect, beginnings of the pandemic, we were seeing probably almost 90% of our patients through Zoom. And as the regulations got a little bit more lax, we're able to see probably 90% of our patients in office. Patients that are coming in from, you know, say from the States are definitely doing virtual consults. So, and initially the reconstruction that we were doing, everyone was that worked to get autologous reconstruction would get expanders, because we didn't have time or not doing large operations at that time. And if they currently, we're so backed up with what happened initially during the fall and summertime, at the beginning of summertime. Most of the patients are getting expanders just to convert them from active to non-active, and then come back and do an autologous reconstruction. It's not ideal, but we just have to deal with the situation that we're currently in and you know, make safe decisions.
Yeah, one of the things that happened here in Phoenix, we just crested a surge a few weeks ago. When we first entered the pandemic in March, we had a 30-day, actually I think it was more than 30-day, but we had a moratorium on all elective surgeries. So the autologous procedures were considered elective. So all the deeps, actually I think all over the country, the deep surgeries stopped. Those are going again. And when we really peaked on our caseloads with the COVID patients the last month, we didn't shut all of our hospitals down and our ORs down like we did the first time. We went hospital by hospital, and we had some of our major hospitals were completely overrun, and they had to turn the recovery rooms, the post-op recovery rooms, into ICUs. And what we did is we just transferred the patients who were scheduled to have surgery at those particular facilities to another facility. And a lot of, particularly in the major metro areas, a lot of the surgeons will have privileges at multiple different facilities. So going forward, I don't have the angst that I had back in March. I think that our cancer patients need to be treated. That's not an elective surgery. I think that we've learned how to shuttle patients back and forth. So anyway, I think we're not going to see delays in care with the cancer. I think that when the hospitals become very, very crushed and OR time is precious, we'll be doing more tissue expander placement to defer the deep, until later on when things cool off a little bit. But this pandemic is going to be with us, and I frankly think that we're going to be doing these little peak and valley surges around the country for the next even few years. So we've just sort of found a new normal and a way to keep the patients being operated on in a timely fashion and keep moving forward.
Yeah, I mean, none of us knew how to handle this, but what I'm very happy to hear and what you guys have shared today, just about the fact that patients can still have this coordinated care and shared decision-making conversation with both the breast surgeon and the plastic surgeon. I love the 3 pillars, treat the breast cancer, talk about the function of the woman's body after surgery, and you've got to include the aesthetics. I think, like you said in that hurricane, Dr. Matatov, women forget about that sometimes. So I want to thank you both, really, for sharing all of this information today. And, please comment or question on this video. And if you have any other topics you'd like us to cover, please let us know here at the Foundation. Thank you both for joining us today. We'll see you.
Thank you.
All right. Take care. Stay safe.
Thank you. You too.
Yeah.